if autophagy matters, and I believe it does, is 1 day of fasting a week optimal versus 3 days a month versus 7 days a quarter? I mean, I mapped this out once in one of my newsletters. I have a newsletter I send out every Sunday, and I mapped out all the permutations. So I call it the fasting function. So F is a function of X, Y, and Z. So X is the amount that you restrict calories. So a water-only fast would be 100%. A hypocaloric fast might be 70%. Y is the duration of this intermittent fast. So 1 day, 5 days, 7 days, etc. And then Z is the frequency with which it's repeated. So if you're doing a 1 day fast a week, you're doing 100%, 1, 7, right? Yeah. 1 day every 7. I do 100%, 7, 90. Every quarter, I do a 7-day fast. I think a reasonable protocol is probably 100%, 3, 30, 3 days a month. So if you go through all of the combinations of these and come up with ones that are physiologically reasonable, I think my back of the envelope calculation is there are 50 different fasting regimens that we would all call intermittent fasting regimens. So point number one is anybody who says theirs is the best is either delusional and completely incapable of understanding combinatorial mathematics, or they're lying. And two, we shouldn't be in a situation where we have 50 things to choose from and we don't know, at least by some semblance, how to rank order them.
Hey friends, welcome back to another show with Peter Attia. It's a good one. And this episode is brought to you by our friends over at perfectketo.com, the suppliers of a range of products to help you along your ketogenic diet and lifestyle change, including low-carb, high-fat, whole food-derived protein bars, and some of the best-tasting nut butters that are out there infused with MCT oil powder. So definitely support our podcast and support your body's metabolism by going to perfectketo.com/HIH and use the promo code HIH at checkout. Again, that URL is perfectketo.com/HIH. Now, in today's show with Dr. Peter Attia, we start out with endurance athletics. So if you're not an endurance athlete, if you don't care about cycling, you may want to just, and I'm not saying this information is unimportant, but because both Peter and I have a background in endurance athletics and cycling specifically, that's where we start the conversation. Then we talk about autophagy mechanisms, some of the mechanisms that are associated with longevity. Looking at these, we talk about mTOR, we get into rapamycin. He talks a lot about rapamycin, the history of rapamycin and mTOR inhibition. As many of you know by now, mTOR is a growth factor signaling nutrient sensing kinase, if you will, but it does inhibit autophagy. So there is a lot of research about inhibiting mTOR in the realm of enhancing autophagy. We talk about that. Then we transition further into different applications in the context of intermittent fasting, time-restricted feeding, and we dive into, the ketogenic diet and blood sugar regulation. But it's a really, really good show. There's a lot of resources and links below this video in the YouTube description and the associated timestamps and transcript that you may be interested in, as well as the audio version of this interview over on iTunes. So I really hope you enjoy, and if you do, please hit that like button, share this with someone that you care about, and let's dive back into it with Dr. Peter Attia.
So about cycling, so I was a Cat 2 cyclist, so I raced.
Okay, yeah, so you know
so
both
familiar with. Yeah, I wish I had lactate testing back then. That would be kind of cool to tinker with.
Yeah, well, when were you doing it? I mean, they did.
2008 to 2000.
Oh, yeah. I was lactate testing like in the early 2000s. It's a bit of a pain. And that's different. Time trialing lactate testing is very different from lactate testing I do now, because that's lactate threshold. Like sure. In a time trial, you want to sort of, if let's say you're doing a 40K, you want to be at about 4.5 millimolar for the entire race, and then in the last 5 minutes blow up.
Right. Otherwise,
so I would usually finish that at about 14 or 15 millimolar. But at any point during a repeatable interval, I'd want to be at about 4.7 to 5.5.
Interesting. So when you're getting lactate levels of 17 millimolar?
Today. Yeah. So say 20 would be how I would get on a Tabata. That's just a 4-minute all out.
Okay.
I mean, it's how it works. It's like 20 on, 10 off.
Yeah.
For 4 minutes, yeah.
And what kind of power? Like, what's your average power?
Yeah, so it's on an air bike. So, and it's hard to say average power because it takes a while to get up, and then you have it off. But I just want to make sure during that 20 seconds on, I'm hitting at least 8 watts per kilo. And And I would think that somebody who's really fit, who's doing, like if I were to have done this type of Tabata 5 years ago, I'm sure I'd be at 10 to 12 watts per kilo.
Yeah.
Like I don't really train that energy system anymore.
Interesting. So to race in the tour, isn't there a metric like that? How many watts per kilo you're putting out?
Oh yeah, absolutely. I mean, back in the day, the tour was won or lost, barring, sort of a technical, mishap, strategic mishap, crash, mechanical issue. You could basically line up all the GC contenders at their FTP in watts per kilo, and that's going to predict the winner. And, it's impossible to say, because the sport has never been clean, and it never will be clean. So, by the way that people want to believe what clean means, which is sort of a goofy definition, but certainly in the heyday, you needed to be in the high sixes, low sevens in FTP watts per kilo, which is that's mind-numbing to me.
Yeah. So clean meaning EPO, GH, everything else.
If you want to define clean, clean would be everything that is on the WADA USADA ban list is not being used in any form, in any derivative, in any out of season, in season. Like that would be clean, and that's never happened, and that's never going to happen.
Right. At that level, I mean, do you think any sport is truly clean at the elite level? And I was thinking even like when I was racing Cat 2, there was definitely guys that you could tell by the striations in their quad and gas rock that they were on something.
Yeah, I mean, it's really funny. There are some sports where you get the sense that the doping just isn't as rampant, at least at the U.S. level. Like I've always thought swimming is pretty clean. I think the U.S. swimmers are generally pretty clean. And whereas we see it in other countries, that's not necessarily the case. But I think cycling is just by its nature, like the Tour. I mean,
it's so hard on the body. 3
Yeah,
weeks. I mean, with that,
I can't even fathom. I mean, the most I ever did was like 3 back-to-back days of 100+ miles at race pace.
you're
3
trash
days,
for
just
like,
3 days. Yeah. You're gone. You take 3 days to recover from that. So now, admittedly, I'm not that good.
Sure.
So, but it doesn't matter how good you are. I mean, 21 days of racing instead of 24 days or whatever it works out to. I mean, it's incredible.
It's a lot. I mean, the stress on the body. I think at that level, I've had this theory that like the elite athletes, they just recover better.
Oh, for sure.
I think that's part of a metric that we talk about, like building size, power to weight ratios, things like that. But I think a big aspect that's underutilized or under talked about is that recovery.
Yeah, and also the other thing that's sort of missed with the best and the best and the best of the world is they've never really taken great lengths of time off. And if I go back and look at what my anaerobic output was when I was sort of 15, 16, 17, 18 years old, it was like superhuman. And the worst thing that ever happened to my conditioning was going to college, because basically I had to go from training 6 hours a day to training 2 hours a day. But there was something to be said for 6 hours of training a day, every day for 5 years. And I've never even come within 25% of that level of fitness.
Sure.
And I think that there's just something to be said for uninterrupted periods of
just volume.
Incredible volume, incredible intensity before the system breaks.
Now, along those lines, the volume, the capillary density, the mitochondrial biogenesis, like what specific mechanisms of that volume do you attribute to better success when it comes to specifically endurance athletics?
It's a good question. I mean, one thing on lactate clearance, I do think, and I've never been able to sort of demonstrate this, though I actually tried to get an IRB here in San Diego to approve muscle biopsies for some work I was doing with athletes back when I worked with athletes, which I don't do anymore. But I do believe that one difference between me and a world-class athlete is the density of MCT transporters in their muscle. So I think they are much more efficient at getting lactate back into circulation, back to the liver. And I do think you can train that. I mean, I think there are some people that are going to be born with, just as we see a spectrum of height or, strength or any, characteristic that matters genetically, you'll see the same thing. But I also think that can be trained. And I think
they're inducible.
Yeah, I do. I mean, I believe it's inducible. I've seen some animal data to suggest it. And I had an interesting idea for an experiment that you could do in cyclists to see over a 3-month period if you could induce it. But you would need to do muscle biopsies to demonstrate that.
To get that.
And we couldn't get an IRB for it.
Wonder why. It wasn't...
it was just... I don't know, it was deemed like
No one
really
cared.
invasive, you know.
Yeah.
I mean, a muscle biopsy is obviously much more invasive than, you know, a blood test or something like that.
So I've had this theory about fat adaptation, like on the ketogenic diet. Is it partly, you know, the ketogenic pathways within the hepatocytes, the liver and so forth, or the MCT transporters in the CNS or throughout the muscle tissue? And it appears some SNPs within the MCT different proteins. So you've seen some data, at least in animals, to suggest that they're inducible and we can train them to.
Yeah, I've seen animal data that you can induce that through the right type of training, which is basically an incredible exposure to lactate.
Yeah.
Because remember, I mean, lactate gets a bad rap, right? Everyone thinks lactate's bad. Like, lactate's an amazing fuel. In fact, there's evidence that the brain can actually utilize lactate as well as glucose. The bad rap comes from the hydrogen ion that accompanies it. That's why we all, you know, don't like lactate.
Because it's acidic nature, or
Yeah, lactate's just buffered with a hydrogen ion. It's actually the hydrogen ion that is causing the stiffness and the pain that you get when you're at an all-out exertion.
Interesting.
It's the hydrogen ion that's preventing the myosin-actin filaments from releasing. So like earlier today when I was doing that miserable Tabata, you know, 3 minutes into that, I really was losing control of my legs. Like, I couldn't make them go as hard as I thought they should be able to go.
Right.
And they felt like they were seizing up and like someone was sort of ripping into them. And that actual discomfort is because of the hydrogen ion and the inability for these myofilaments to release, not the lactate per se. So we measure lactate because it's easy. But I'm sure if we measured pH, we would see it accompany it. So pH would go down as lactate goes up.
And then so through adaptation, then you're able to get that lactate out and recycle it via gluconeogenesis in the liver, or just dispose of it? I mean, I guess.
Well, yeah. So the number one fate of lactate is the Cori cycle in the liver, which will turn lactate back into glucose. Although there is data that shows that that the brain can actually use some of that lactate directly as a fuel.
Yeah, and there's.
Although I suspect the liver is the dominant place where you dispose of lactate.
Sure. And isn't there some signaling properties within the brain that are lactate mediated, like they're?
I don't know. I'm not sure. I don't know a lot about lactate.
Yeah,
you know,
it's kind of interesting. I know Rhonda Patrick has talked about it for quite some time. Yeah, interesting. Well, so this morning, so every Sunday I fast and have been encouraging people on social media to fast for 24 hours every week. So this morning I turned on my Zero app, and so I cut my feeding window off at like 5 p.m. yesterday, and then a pop-up came up and said, do you have any questions for Dr. Attia? And it was so funny because I was at a coffee shop here in San Diego. So autophagy is a big clinical area of interest for you.
Yeah.
Right? What aspects about autophagy are particularly exciting for you?
Well, I mean, I think just taking a step back, it excites me because when you want to understand longevity, you don't get to point to human clinical trials. You know, it's not like studying antibiotics and their efficacy against, you know, this bacteria, that bacteria, or antivirals and their efficacy against HIV, where you can do discrete, neat, clean, you know, human clinical trials and get answers. So when it comes to human longevity, you're stuck using what I consider these two important but imperfect bodies of literature. So one is the human literature, which is backwards looking and therefore subject to lots of mistakes, but looking at the centenarians and understanding what it is about them genetically and phenotypically that have, you know, given them this incredible gift of longevity. And you can extrapolate from that what mechanisms might matter to longevity. What is it about a centenarian that, despite all of the things they do wrong, and they do everything wrong, they're no more likely to eat well, exercise well, sleep well, manage stress well than the average person. In fact, on average, they're slightly worse. So what is it that, despite that, gives them this incredible, basically 20-year advantage in life over everybody else? And then the second, so I call that sort of pillar one. Pillar two is all of the animal data, or I would say more generally the non-human data, because it really includes everything from yeast to mammals. But here you have the advantage of doing experiments. So experiments allow you to control these variables because they're prospective. You can actually tie intervention X to outcome Y. The drawback, of course, here is you're not looking at the species of interest. So it would be great if all we cared about was C. elegans living longer, but presumably you and I care about living longer ourselves. So what you have to do is you have these two imperfect pillars, and you sort of extract from them what you believe are the mechanisms that matter, and that becomes the foundation. And so one of the mechanisms that emerges as incredibly important is autophagy. And you could point, certainly coming from the animal data, the only two interventions that really seem to offer longevity over this billion-year hurdle of evolution, so everything from the yeast, flies, worms, mammals, the only two things that seem to uniformly, if done more or less correctly, impose longevity are rapamycin and some degree of fasting. So you then start looking at, well, what do those two things have in common? Mm-hmm. Well, what they both have in common is they would certainly turn down mTOR, mechanistic target of rapamycin, and there are lots of other effects that come with it. Now with rapamycin, there are probably other things that are happening that go beyond just the reduction of mTOR, or maybe more to the point, there are probably other things that are happening besides autophagy going up. So we would see inflammation go down, we would probably see mitophagy go up, we would probably see senescent cells getting suppressed. And those things tend to happen when you're fasting as well. All of those nutrient systems are kind of coming down into, a nutrient-deprived state, which means insulin is going down, IGF is going down, PI3K is going down, AMPK is going up, TOR is going down. So one of the important mechanisms that's seen in that Venn diagram that would overlap between rapamycin and fasting would be autophagy. Mm-hmm.
Super interesting. So rapamycin, I know you shared a paper, I think it was a buddy of yours had written about, should we look at rapamycin for Alzheimer's?
Yeah, that was Matt Kaberlin, actually in your neck of the woods. He's up at the University of Washington.
Cool. I'll have to look up his research. So why is this compound? Is it hepatotoxic? Is there issues with it? Why are we not using this in a pharmaceutical context?
Well, we do, but we just use it for something that's entirely counterintuitive, which is immune suppression. So rapamycin was approved in 1999 by the FDA for immune suppression. So it's used in patients who have had organ transplants, kidneys and livers being the most common, but also heart and lung. Because when it's administered in a certain way, which is at modest doses, day in and day out, it has remarkable anti-proliferative properties. And one of the cells that is most susceptible to that are T cells, which play such an important part in regulating the immune system, or more specifically, the branch of the immune system that would reject an organ.
Which is
Well, so this is what we call the adaptive immune system, that is not the one that's necessarily getting rid of bacteria, but more the one that's going after viruses, cancer, and recognizing and distinguishing self from non-self.
I see.
So it was discovered back in the 70s. Well, so rapamycin, of course, you know the whole story of it, I'm sure. We won't have to go into it.
Actually, I don't. I haven't read it. Yeah, if you want to dive into it.
Yeah, it's one of my favorite stories in biology.
Cool.
So in 1963, 1964, an expedition from Canada went to Easter Island to study a number of things. They wanted to study everything about the ecology, do some bioprospecting, do a whole bunch of things, because Easter Island is such a remote area. In fact, I believe it is actually the most remote civilization in the world, meaning it's the most remote place that has a population at a greater distance from the main population.
On the East Coast?
No, so it's off the west coast of Santiago.
Okay.
It's about a 6-hour flight due west. So it's a little further from Santiago than Hawaii is from the west coast of the United States.
Wow. Okay.
And it makes up one of the 3 corners of Polynesia. So they went there and they did a lot of really interesting stuff. And there's a very famous volcano there at one corner of the island, and they dug up a whole bunch of interesting soil that presumably had organisms that had not been seen elsewhere. And several years later, a bacteria was discovered within there that had never been discovered before, called, I believe it's Streptomyces hydroscopicus. So this bacteria produced a chemical. And that chemical turned out to have really interesting properties. So it was incredibly suppressive of anything that was proliferative. And the first thing they looked at was yeast. So it would basically shut off the ability of yeast and fungus to proliferate. And so the scientist who discovered this, his name was Suren Segal, thought he was really onto something interesting. He thought he was onto the cure for athlete's foot, actually.
Wow.
And he was at the time working at a pharma company. To make a very long story short, that pharma company was acquired by another company, and he was told to shut down that project. But he felt so strongly about this that he kept it in his freezer in his house for about a decade.
Wow.
When the company that his company was sold to was ultimately bought by Pfizer, he brought it back out of, it was bought, anyway, Pfizer bought it after the next company that bought it. But when another acquisition took place, he brought it out of the freezer and said to his then bosses, hey, I've got this interesting compound that's sort of been doing nothing for 10 years. Do you mind if I resume work on it? And they said, sure. So he got back to work on it. Now, he named it rapamycin in honor of the Rapa Nui. So the Rapa Nui are the people of Easter Island. So it's called rapamycin to honor where it was discovered. And the work went on through the mid-'80s into the mid-'90s, and by the late '90s, this in fact was approved as a drug to suppress the immune system. And it really was one of the game-changing drugs in immune suppression, because you can suppress the immune system with a lot of ways, but every way comes with its own set of side effects. And the typical way you do it is with corticosteroids. But they come with just so many awful side effects that you're always looking for something a little bit more sophisticated. And so cyclosporin was a big breakthrough in the 70s and 80s. And then this drug became the next generation breakthrough.
Interesting. So it would be off-label use then to use it for something else?
That's right. It took 10 years before anybody thought to ask the question in a different way. So it wasn't until 2009 that another paper came out that set forth in motion an onslaught of additional research that said, well, wait a minute, if rapamycin works by suppressing mTOR, and we know that at least transiently that's really a beneficial thing, there should be something else about rapamycin that could be very valuable. So the first study I believe that came out, which was I think it was in 2009, looked at mice, both male and female, and it began administration quite late in life, which was about 600 days, which for a mouse is very old. That's like a slightly beyond middle-aged mouse. And it's important to note that very few things can extend the life of a mouse that far out. In other words, even if you start calorically restricting a mouse that late in life, you don't see much of a benefit. You usually have to start earlier. And yet, despite that, the rapamycin-administered mice were living, I believe the males lived 9% longer, the females 13% longer, which was of total lifespan. So of additional lifespan, it was in 20-25% additional lifespan. Wow. Which is pretty significant. And those results have been replicated over and over and over again and across multiple species, which is what makes 10 years later rapamycin, to me, probably the most interesting compound when it comes to longevity.
But there's no human clinical trials to use it in this context at present?
No, so Matt Kaberlin, who's in your backyard, is studying it in dogs, and the results are really exciting, in companion dogs. So here you have large animals that are in our environment, so subject to all of the same toxins that, exactly. Yeah. And in his shorter period of 12 weeks, he's seeing improvements in cardiac function, because dogs are really susceptible to a cardiac disease we don't get in great abundance, called cardiomyopathy. So we get atherosclerosis, which ultimately damages the muscle, but they get a disease that goes straight after the muscle without harming the arteries. And that cardiomyopathy probably accounts for, among their top 3 causes of death.
Interesting.
So he's showing that with rapamycin, you can add 10% to the ejection fraction of these dogs within a period of as little as 3 months.
Wow.
So it's early data, but it's super exciting, and it's congruent and consistent with kind of what we see in other models. So yeah, to answer your question, there are no human clinical trials to my knowledge, although I've heard of people kicking around the idea of doing an Alzheimer's trial, so probably targeting patients who are in the earliest stages of cognitive impairment or dementia, and then asking the question, could rapamycin extend their useful cognitive time or even reverse these changes. Now, there's other compounds that are sister compounds. So everolimus is a sister compound to rapamycin. It has been studied in humans, and it's been shown that in as short a period of 8 weeks of administration, followed by 8 weeks of washing out, it enhanced immunity against an influenza vaccine in people that were 65 years old. Also very counterintuitive.
Yeah.
Because you'd think it's an immune suppressant. It shouldn't make their immune system stronger, but in fact it did. And these results are being replicated, again, by another company that has acquired the rights to everolimus, which was previously at Novartis. And so now they're combining it with other agents and looking for these other easier clinical outcomes to measure. Infection's an easier thing to target than longevity.
Right. Really interesting. Now, is this something that a patient could get a script for now and use it off-label? Because There's different compounds like methylene blue is being used totally off-label.
Yep.
By the way, have you experimented personally with that?
Oh, it's funny you bring that up. I will be shortly. I'm just in the process of getting a compound pharmacy to make something that I will be happy with, because as you probably know, the thing you want to be careful with methylene blue is if it has even 1% contaminant in it, it can be actually harmful.
Okay.
So we're trying to find something that is pharma grade pure, and yeah, I'm very interested in it, especially after the interview that I did with Francisco Gonzalez Lima at the University of Austin. He and Jack De La Torre are doing incredible work with methylene blue in patients with cognitive impairment.
Interesting.
And mechanistically it makes a ton of sense given its activity in the mitochondria. So yes, you're right. Rapamycin can be written for by, it's a perfectly legal compound, within the confines of medicine, so anyone could acquire a prescription for it. But it still begs the question. I don't think we know exactly what dose to take it and at what frequency.
So you personally don't recommend it, or have you gone into that?
I take it personally. I have never written a prescription for a patient on it, and I probably wouldn't be comfortable doing it for quite a while until I gathered more information. My bar for treating myself is a little lower than for treating a patient. So, obviously I think what I'm doing is beneficial to me, but getting back to your question, I would like to confirm that I'm actually seeing an increase in autophagy, an increase in immune function, no deterioration in glucose homeostasis, all of these things that should be happening if you're using the drug correctly. And
so you're tracking those proxies to kind of
I'm not tracking
triangulate.
autophagy, which I think is one of the most important ones, because we don't have a way to measure that in humans easily.
Yeah, that was going to be my follow-up question there. So what about telomere testing? Are you looking at your telomeres to see?
No, and I have to be honest, and I know this is very unpopular and politically incorrect to say, I just don't think that's that interesting. It might be interesting in the context of 100 other markers, but telomere length in and of itself is so easy to manipulate with so many other things. And, to me, it might almost be like hair color. Yes, your hair gets grayer as you age, but if you put color in your hair and your hair goes back to its natural color, does that mean you've slowed the aging process? I'm just not sure. So I think the biology of telomeres is very interesting, but I'm not sure it's the right metric to track. I think we need sort of deeper stuff.
Yeah. So basically, if I inferred correctly, we're triangulating. Glucose, ketones. What else? Subjective feelings of well-being?
With rapamycin specifically?
Autophagy enhancing.
Yeah, you really need a set of tools that have never been developed before. In laboratory animals, we infer what's happening in terms of autophagy, usually once you've sacrificed the animal, by looking at the conversion of different types of things called long chains, which are microtubules, which if a cell is undergoing autophagy, which for the listener, I guess, just to be clear, is sort of self-eating, right? So autophagy, self-phagy, eating, is when these lysosomes basically auto-digest the cell. So they have these chemicals in there that will break down the constituent products of a cell. And when you see this happening under a microscope, you see these microtubules, these things that are growing like, they're like the poles of a tent, basically, that are, changing the morphology of a cell. And so for me to sort of take a biopsy of your muscle right now and try to put that under a microscope and see if you have those microtubules because you're fasting is not practical. So what is probably needed is to develop a signature of autophagy that can be measured in the blood.
Metabolomics.
Exactly. It'd actually be all of the above. I think it would be metabolomic, proteomic, small molecule, large molecule. It would be everything. Probably a signature in the gut as well. So. And you could develop that signature, I think, by presumably, cross-referencing it with biopsies. So you'd have to do some of that at the outset, and using, clinical situations where you just know autophagy is taking place, like a really prolonged fast.
Right.
My intuition says something over 3 days with only water would probably be sufficient to induce it. But again, this is sort of the frustration of this is. We're really limited by the tools.
Totally, yeah. But a lot of people have these different theories on the internet, like no water during a fast, water during your fast. 36 hours, that's enough. No, not enough. And what's interesting to me is the data that we have surrounding exercise and inducing autophagy genes and looking at transcription factors. But to my knowledge, and please correct me if I'm wrong, I don't know of any human clinical trial in humans showing fasting has upregulated or induced autophagy genes. And
yeah, I think that's correct. At least by my reading of the literature is correct also. And I think that's going to change because I think people are starting to realize, just what we said earlier. If there's a whole app around fasting,
right.
People are interested in this, and I think it is the single most potent tool within our toolbox of nutrition. There's nothing more potent than not eating
right.
periodically. So, yeah, we should know the answers to these questions. It really frustrates me to not know the answer to something that seems so important, and also I think so knowable.
Right. Interesting. Now, why do you suggest that 3 days?
3 days is just my intuition, and that's only based on my own data. Right. And the data of my patients. So, I usually wear a continuous glucose monitor. I'm sort of wearing one probably 300 to 330 days a year.
Which one?
The Dexcom G6, yeah. So of course I'm wearing that during all my weeks of fasting, and there's definitely something that changes in the third day. So whether it's, 56 hours or 62 hours, or I don't know exactly, and maybe it's not fully 72 hours, but the first 2 days, there's a lot of movement around glucose.
Yeah.
And then by that third day, it's gone.
Flat.
It is absolutely gone. My glucose is pretty much just below 3 millimolar, or just below 60 milligrams per deciliter. And the only thing that can make it move is exercise, which I still exercise every day when I'm fasting. So I'll still see a rise in glucose in response to that. So we clearly know you've come to an equilibrium in glycogen during that period of time. So the liver, which is regulating our blood sugar, down to the minute, is obviously at some steady state now where there's probably, comparable levels of glucose being made in the liver, for example, through glycerol, which you're now going to be making at geometric rates as you break down all of the triglycerides to use the free fatty acids to make the beta-hydroxybutyrate. And, the way I fast is I don't think we're actually breaking down much muscle. So, and the body, even without exercise, I think the body works pretty hard to make sure you're going to preserve lean tissue throughout a fast. So I think there's just sort of a steady state, input in, input out. And so my intuition is that's really when the body is in a fully calibrated mode of fasting. But again, I have no way of knowing that. This is a speculation, and therefore we should know the answer to this question because it has an enormous consequence for how we would recommend patients fast. If autophagy matters, and I believe it does, is 1 day of fasting a week optimal versus 3 days a month versus 7 days a quarter? I mapped this out once in one of my newsletters. I have a newsletter I send out every Sunday, and I mapped out all the permutations. So I call it the fasting function. So F is a function of X, Y, and Z. So X is the amount that you restrict calories. So a water-only fast would be 100%. A hypocaloric fast might be 70%. Y is the duration of this intermittent fast. So 1 day, 5 days, 7 days, etc. And then Z is the frequency with which it's repeated. So if you're doing a 1 day fast a week, you're doing 100%, 1, 7, right?
Yeah.
1 day every 7. I do 100%, 7, 90. Every quarter, I do a 7-day fast. I think a reasonable protocol is probably 100%, 3, 30, 3 days a month. Someone like Walter Longo has an FMD. That's the name he gives his fast mimicking diet. It probably works out to be about a 75% reduction of calories for 5 days, and they recommend it. They have a lot of different recommendations, but call it every 90 days. So if you go through all of the combinations of these and come up with ones that are physiologically reasonable, I think my back of the envelope calculation is there are 50 different fasting regimens that we would all call intermittent fasting regimens. So point number one is anybody who says theirs is the best is either delusional and completely incapable of understanding combinatorial mathematics, or they're lying. And two, we shouldn't be in a situation where we have 50 things to choose from and we don't know, at least by some semblance, how to rank order them.
Right, and customize them to people's goals or health outcomes.
Absolutely.
Yeah, which is really...
Yeah, because not everybody could do every one, right?
Sure.
I think most people can handle probably 1 day a week, but the question is that sufficient?
Right. No, that's a good point. Yeah. So I personally do then the 5-day every quarter, in addition to the 1 day a week.
Okay. Yeah.
But I'm going to see how I haven't done pre and post DEXA to look at body composition.
You might not see much of a response. That you're sort of not going to be in a great place to see. I don't think DEXA, because DEXA is about plus or minus 1 to 1.5%, and you might not lose enough fat mass and or muscle mass in that period of time. I mean, DEXA is by consumer standards the gold standard, but you'd really need to do MRI to see it. And in many ways, I don't know that it matters. In the end, measurements of your body and photos probably tell enough of the story. The scale is misleading a little bit because you're losing so much water. And part of that is the glycogen. Remember, every gram of glycogen moves with 3 to 4 grams of water. So if you think about someone your size who's got big muscles, your muscle glycogen levels probably go from being full to 60% full. Same is probably true in your liver. If you do the math on how much glycogen you've lost and how much water has gone with it, and that water, of course, is going into the plasma first and then out of the plasma, because your sort of your body is really trying to conserve sodium, so you're going to cut down, you're going to excrete more water. I think in a 7-day fast, if I lose 8 pounds, I think at least 5 of it is water.
And so you don't notice, like on day 8 when you exercise, do you feel weaker, more lethargic? Would you say?
I don't. The only thing I've noticed is my strength is almost unchanged on a fast. My ability to tolerate, like the length of time I need between sets goes up. So if I try to lift as heavy as possible on those fasts, and I do so every day.
Nice.
Again, as a way to sort of stimulate mTOR in the muscle, which is the last place I want to see, loss. And what I wouldn't be able to do during a fast is the Tabata. There's no way I could do that.
Because your lactate's already high?
No, because your lactate shouldn't be that high during a fast, but because that is so dependent on glycogen and probably CK at the beginning, the first burst. And I think those are going to be on shorter supply.
Right. What about heart rate variability? Do you notice a big bump when you start?
It goes up when I fast, yeah.
And what do you think mechanistically? I've looked at ketones and how they affect the vagal nerve, things like that. Is that what you infer?
I don't know. I find this stuff so interesting. Like, I wish I didn't have to work. Like, I wish this could be my full-time job.
Researching.
Just having a lab and just like looking into obscure things that seem otherwise uninteresting to the world of pharma and everybody else. But like those are such interesting questions. And questions like that would be answerable in animal models, and maybe that literature's been done. You can sever the vagal nerve and get a pretty quick answer to that question about what's being transmitted. Of course, if you sever the vagal nerve and you blunt the effect, it still doesn't tell you what the proximal mechanism is, because the vagal nerve plays such an important role in mediating parasympathetic flow, which has to be what's going on, right? There has to be something that's increasing parasympathetic control and decreasing sympathetic control. But yeah, no, it's interesting. My head of research, Bob Kaplan, has a saying, which is not his, but he just always reminds us of it, which is like, the further you go from shore, the deeper the water gets.
Yeah,
so
right.
My relative understanding today is much lower than my relative understanding was 5 years ago, though my absolute understanding is probably slightly higher.
Makes sense. What I've read is the BHB activation of the vagal nerve to kind of calm down sympathetic drive, because the catecholamines help with lipolysis and all the mechanisms associated with making the backdoor energy source for the brain, the ketones. And so that's one mechanism that's been proposed. I don't know if it's valid. I think it's kind of interesting though.
Yeah, and again, those things would be measurable because, catecholamines can't be measured in the serum because they don't stick around long enough, but you can measure their metabolites in the urine. One of the things I do when I fast, because I do blood tests right before, right after, is I also measure urinary cortisol levels and all of the cortisol metabolites, though I don't measure many of the epi and norepi metabolites. And interestingly, I don't see an enormous change in my cortisol levels during the fast. And you could argue that it would be stressful enough that they should go up, or that the body sort of gives up and lets them go down. But again, with an N of 1, I think it's hard to make much of
inferences. You know, a lot of people kind of speculate on the internet that if you have a quote unquote adrenal fatigue, and we've had Carrie Jones on the show several times and kind of have debunked that oversimplified. But if you, so to speak, have HPA axis dysfunction, that you shouldn't intermittent fast or you shouldn't fast. What are your thoughts there?
I don't think I know the answer to that question. Because again, and I mean, I think Carrie knows this stuff really well. I've learned a lot from her. So the concept of adrenal fatigue is so strange to me that people still use that term. And so when you talk about HPA dysfunction, there are so many ways that can happen. I don't know. I mean, I think there are so many things that are driving HPA dysfunction. Probably the most common one that I see in a clinical setting is bad sleep.
Yeah.
So lousy sleep hygiene, which is unfortunately the default state for us in this world, probably wreaks more havoc on this. And so if the question is someone with bad sleep, should they be fasting or not be fasting? I don't know, but I would flip the question and say, if your sleep is bad, let's get your sleep fixed so you can start fasting.
Reprioritize.
Yeah.
Interesting. When you fast, I mean, so you go to New York all the time. Like, how do you buffer the circadian rhythm disruption, the potential EMFs in the airplane? Like, do you fast during that week to kind of mitigate some of that, or?
Well, I always do my fasting weeks in New York, but that's just more a function of just the ease of not being at home, where the temptations. And again, I think for most people, like, fasting is actually easier than dietary restriction. Dietary restriction meaning like not eating, carbs, not eating fat, not, whatever form of dietary restriction, because it's so binary. Yeah. Like when you decide, like, I'm fasting, you're fasting, and that's the end of it. But it's just easier to do when you have complete control over your environment. As far as the 3-hour time zone difference, it doesn't really faze me. I'm pretty used to it, and my body stays on a similar schedule, because in California I'm really early to bed, really early to rise, and in New York I'm later to bed. So I actually am within 1 hour of the same.
Good.
So for example, I'll go to bed at 9 o'clock in California, 11 o'clock in New York, and I'll sleep 8 hours on both of them. So with the time zone difference, it's really only a 1 hour shift to my body.
Pretty easy to mitigate.
Yeah, and I'm using so many other, I hate the word hacks, but I'm using all the other tools at my disposal. Like, I've got chili pads in both places. I use, a special type of eye cover that really, really makes it incredibly dark. I keep the room incredibly cold. Pretty thoughtful about alcohol and food consumption as it pertains to sleep time and stuff like that.
Mouth tape. Try the mouth tape.
Yeah, I look forward to giving it a try.
I want to see what
you use a single strip?
I do just a single. I found that one, the 3M. I have no affiliation with them, but I just found that one to be the least invasive, easiest to tear. I use a little like red, little like hiking light, at night. So, when I'm walking around doing things, so it's easy to do in bed.
Okay.
But one thing that I had a question on, the muscle loss associated with fasting. Yeah. And you said the way that I fast, I don't personally notice any changes. Is that because you're driving that MPS, muscle protein synthesis, through your exercise while you're fasting? You feel that?
I think so, because here's the thing. I mean, the two amino acids that I think are probably most interesting in fasting are methionine and leucine, because they both play such an important role in muscle. Yeah. And methionine levels drop really quickly once you start fasting. So a day of not eating, I don't know if it's a day, but very quickly you will have unmeasurable levels of methionine. But you know what? Your leucine levels will be about the same. And 7 days in, your leucine levels are about the same. And that tells you that the body will go to great lengths to conserve leucine. And leucine is absolutely necessary for the maintenance of muscle protein. Now, I don't think you can add muscle mass during a fast very easily, because that seems to require supplemental leucine, or leucine to hang around a lot longer. So I think that so two things are happening. One, you have enough leucine during a fast because the body is doing such a great job to conserve that. And by driving the exercise, you're creating the demand to maintain muscle mass. And that also tells me that you don't need methionine to maintain muscle mass, though you might need it to increase muscle mass, as you do with leucine.
Interesting. And so that stimulation will preserve Stimulation via exercise.
Again, all of this is completely based on my own experience and the
Totally
experience of my patients who fast. So, you have to take that with a whopping grain of salt. But unfortunately, in the absence of really good literature, these are the best answers I have.
Yeah, it's interesting. What about thyroid hormone suppression? That paper with Oliver Owen. So he found in these overweight individuals fasted, I think, 19 days, T3 and T4 decreased by, I want to say it was around 30% in the first 3 days. But after that, they were relatively flat. And they proposed that was a mechanism to inhibit muscle protein proteolysis and preserve lean mass. And I was really curious what your thoughts are.
Yeah, so to me, the change in thyroid function is by far the most interesting biochemical change I see in myself. And I haven't even come up with a way to thwart it, or even an understanding of whether I should be trying to thwart it. So T3 and T4 only tell part of the story. You have to look at reverse T3 as well, because it's reverse T3 is our body's big buffer. So the brain makes TSH. The pituitary gland makes TSH in response to the hypothalamus telling it to make TSH. The TSH tells the thyroid to make T4. Now, T4 is inactive. The body has to do basically three things with T4. There's part of it gets converted to T3 in the brain. And so the brain's ability to see T3 is what regulates TSH indirectly. The body makes T3 in the periphery, outside of the brain. And that's what is the active hormone. That's the one that's sort of driving the changes that we expect a thyroid hormone to be able to do. But the body can also turn T4 into reverse T3, RT3. And each of those three things is controlled by different enzymes called deiodinases. And so the environment is what upregulates and downregulates those enzymes. So in a fasting state, the body is upregulating, and I believe it's D3, but I can never keep the names of these deiodinases right. It's upregulating the one that I think is D3, but the one that is turning T4 into reverse T3. And it upregulates it like crazy, because the body is basically saying, nutrients are scarce, slow down metabolic rate as much as possible. And it's downregulating D1, which is the deiodinase that turns T4 into T3. So if you look at free T3 and reverse T3, that ratio gives you a sense of peripheral thyroid function. So in a normal person under normal circumstances, that ratio is usually greater than 0.2 to 0.25. And so let me give you some normal numbers. Like you would expect to see a free T3 of 3.0 and a reverse T3 of 10. So that's a ratio of 3 to 10 is 0.3. Totally normal. And let's say the TSH is 2. So if I look at that and know nothing else, I will say, you know what, these deiodinases are in balance. The TSH is normal. That tells me that the brain is seeing the right amount of T3 and it's regulating T4. The free T3 is normal, so the body is doing the appropriate conversion. And the D3, or whatever the bottom one is also appropriate. It's got just the right amount of counterbalance. Because reverse T3 is an anti-T3.
Right.
Okay, so
let me pause you there. It sits in the receptor and inhibits T3?
Yeah, I believe it's a competitive antagonist.
That's why I've thought too. Someone corrected me on Instagram to no, it doesn't do that. And I could have
believe
sworn I
it's
read
a
that.
competitive antagonist, meaning, because you have two different types of antagonism. Competitive means it sits in the receptor as well, but it doesn't activate it.
Sure.
Yeah.
Okay.
So the numbers I gave you are my sort of typical numbers. So I kind of walk around with a TSH of 2, and sometimes it's 1.6 and sometimes it's 2.7. And I'll walk around with a free T3 that's typically in the neighborhood of 2.8 to 3.5. And I'll walk around with a reverse T3 that's typically like 8 to 12.
Okay.
So that's me on day 1 of the fast. Well, come hell or high water, and I don't know how many times I've done this now, on the 6th or 7th day of that fast, my TSH is unchanged, which is really interesting. That says my brain is still seeing the same amount of T3. So it's
centrally.
As far as my central processing goes, my brain is like, keep making the same amount of T4. My free T4 is quite low. I didn't talk about free T4 earlier. My free T3 is very low. It's about 1.5 to 1.7. And my reverse T3 is in the 30s, typically 35 to 40. So my ratio will go from, say, 0.3 or 0.35 to 0.05.
Oh my gosh.
Which means I have had a complete and total peripheral shutdown of thyroid function. And I feel it, right? I mean, I am incredibly cold when I'm fasting. I just seem more sensitive to cold. And I suspect that also explains why I don't really lose that much weight when I'm fasting. It's not like my body's being ripped apart. And so I suspect that if I did indirect calorimetry, which would be the gold standard to measure my metabolic rate before the fast and after the fast, it wouldn't surprise me if I've seen, a 50% reduction in my metabolic rate.
That big of a swing, huh?
I mean, again, we'd have to measure it to know, but it wouldn't surprise me.
What about constipation?
Well, the funny thing is, when you're fasting, you just, it's hard. Nothing's really happening unless you're screwing around with your magnesium. Right. So that would be another really sensitive way to gauge it. But of course, the irony of it is you're not eating, so you're not going to have it. Yeah. And also, I think some of the longer term things just don't develop. The dryness of skin, the brittleness of nails and hair. You're not, that would be more of a chronic thing. Now, I've even tried on one of my fasts taking supplemental control release T3. So having a pharmacy make T3 so that you can take it in high doses, because you can't take regular pharma T3 in high doses. It's called Cytomel. It's immediate release. And anything more than about 10 micrograms of that will have you jittering off the wall. But you can take a control slow release in pretty high doses. So I think on the last fast I did in January, I think I was taking 25 or 30 micrograms of control release T3, and my hope was that would offset the thing. Didn't do a thing.
Really?
Yeah. Which of course then begs the question, maybe I shouldn't be tinkering with that system. Like maybe that's a part of what you want to happen.
Right.
And it's more just out of curiosity that I tinker with it. And of course the other thing that happens, so if the thyroid system is the most interesting, maybe the second most interesting is the testosterone system. That just completely shuts down as well. So I probably walk around with a testosterone of 14 nanograms per deciliter, free testosterone, so that's about the 50th percentile of the population. At the end of one of these fasts, I could be at 2, 3, 4 nanograms per deciliter. That's more than 2 standard deviations below the mean. And what I find interesting is, despite having the testosterone of a girl by the end of the fast, I don't really feel like I experience a significant reduction in strength.
Or libido, morning erections, things like that.
I don't know. I'll have to pay more attention to that.
Yeah.
I don't think so, though. I don't really think. I'm always surprised to see how low that number is relative to how I feel subjectively.
Going back to the micronized T3, so when you were taking that, were you more tolerant to cold, or was it? It's
a bad experiment because it was January in New York and it's unusually cold. Where I will see it more interesting will be in the summer. Because in my summer fasts, I remember one of the things that always jumps out at me is, how is it that it's like 85 degrees in New York? I'm in a t-shirt and shorts walking through the park and I don't feel warm. So I'll be curious to see if in the summer,
that would be really interesting.
In my July fast, because I do them every quarter, so it's like, the next one will be April, then July. So I'll see what happens then.
Well, so I think a lot of people put a little bit of, what I infer from you just talking about the changes in thyroid hormone right there is that you're not really too concerned clinically that they're shifting around. Yes, they do shift. You're making more reverse T3, but this is a transient process. You're fasting for other health issues. So
all that stuff reverts to the norm. So I'll check my blood then 2 weeks after the fast, and all my hormones are back to normal.
Back to normal.
Yeah.
You see, some people that don't have the medical training that you do think, oh my gosh, fasting wrecked my thyroid. But like you're saying, this is a transient process, and you have to keep the bigger picture in mind.
If any type of fasting is going to permanently alter thyroid, it's going to have to be very chronic. So Mike Rosenbaum and Rudy Leibel at Columbia University did a study using caloric restriction, so not pure fasting, caloric restriction in obese subjects. And what they demonstrated was once a patient lost more than 10% of their body weight, maybe it was 15, but I think it was 10. Once they lost more than 10% of their body weight, their reverse T3 went up significantly, and it would usually halt the weight loss. So that's one of the mechanisms that the body puts in place to halt weight loss, because from an evolutionary perspective, weight loss doesn't really make sense. It's not something we should be doing or would want to do.
Yeah.
And they demonstrated that you could take the brakes off that system by giving T3. And I believe in their study they just used immediate release T3. I don't think they used control release T3. So I think from those data, you could infer that someone who is sort of long-term constitutively calorically restricted may actually see these sort of more significant thyroid effects. But I remember 7 or 8 years ago, there was all of this sort of anti-low carb stuff out there that says, well, low carb will trash your thyroid, your reverse T3 will go up, and blah, 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 blah. And I think a more plausible explanation is any diet that successfully removes weight from you should drive your reverse T3 up.
Right.
So maybe we were just seeing a lot of it because low carb is a very effective way to lose weight, but presumably if you did a low-fat diet or Mediterranean diet or pick your favorite diet and lost comparable amounts of weight, I suspect you'd see a comparable change in reverse T3. Now, so this is one of those things we monitor pretty closely in patients, and again, I'm not a weight loss doctor, so I don't consider this at all my area of expertise, and nor do my patients primarily come to me out of an interest in weight loss. But invariably, people do lose weight when they sort of fix a lot of the things that we're talking about. And so for the handful of patients for whom losing a non-trivial amount of weight, 20% of their body weight, for example, is something that happens over the course of the year, we just pay attention to that. And in our patient population, we haven't always seen that happen. I've seen patients lose. I've got one guy now who's probably at 20% body weight loss in 1 year.
Wow.
He still has perfectly normal thyroid numbers.
So it's not universal.
It's definitely not universal. I mean, there's nothing in biology that's universal that I can think of, except for, the really funny, obvious stuff like
circadian disruption.
Yeah, or like, DNA, RNA, protein.
Right.
Oxidative phosphorylation. Like those things are universal, but thereafter it's pretty hard to make laws.
Yeah, speaking of oxidative phosphorylation, the podcast that you did with Nav was amazing. It was like around an hour, 6 minutes into it when you started diving into the different mediators and metformin.
Around an hour 6.
I was re-listening to that part because I didn't realize metformin's inhibition of complex 1 and the NAD to NADH ratio and so forth. And so do you take NR personally?
I don't.
It's so expensive.
I mean, I did an experiment. Yeah. I took the True Niagen product by Chromadex for 2 months, like 2 years ago, just out of curiosity, just to see if subjectively I could feel anything different. I didn't notice anything. And, I am spending quite a bit of time looking at that literature, and the more I look at it, the more confused I get. I think I'm pretty confident that intravenous NAD does not make any sense.
Interesting.
So I know that's very popular.
Yeah.
But I think intravenous NAD is somewhere between useless and harmful. That is my impression. I think oral nicotinamide riboside, NR, is somewhere between useless and maybe potentially beneficial, but I can't quite tell where it is on that spectrum. And I also think that the route of administration is going to play an important role. So we know, I think, pretty well that when you take oral nicotinamide riboside, most of that is converted to NAD by the liver because of this first pass effect. And what's not clear is how much of the desired outcome, which is NAD getting into the mitochondria, is actually happening. And to my knowledge, nobody's really been able to demonstrate this in humans effectively. And that's not to fault them for it. This is a hard thing to know, right? It's one thing to say how much NR is bioavailable, how much of that NR is converted to NAD that makes it into the plasma, how much of the plasma NAD makes it into the cytoplasm of the cell, how much of that makes it into the mitochondria, and then how much of that starts to impact the NAD to NADH ratio and offers substrate to sirtuins in a sort of different part of the cell. Like, these are really hard things to do. So, I'm incredibly interested in it because that's yet another pathway. We talked about these major pathways, the mTOR pathway, the AKT, AMPK, insulin, IGF, and then of course the sirtuin pathway. I sort of left it out, but it's another really important pathway. And sirtuins require NAD. So there's a good story, which doesn't mean it's true, but there's a very good story for why declining NAD levels would be problematic as we age.
Interesting. I want to get to that. So there was a paper, it was an opinion paper, I believe, about NAD, the ratio, and a proposed mechanism through which a ketogenic diet affects the body. A lot of people are talking about the epigenetic effects, or the impact on histone acetylation, acetyl-CoA is a signaling molecule, NAD to NADH ratio. When it comes to...
I have a call with Eric Verdon tomorrow,
Nice.
who's, Eric was on Rhonda's podcast maybe a year ago, a little over a year ago. And I mean, I think he, on that podcast, gave one of the best sort of master's class explanations of the relationship of beta-hydroxybutyrate and HDACs. Cool. So yeah, I'm excited to talk with him tomorrow. And
is he going to be on your podcast, or you guys are just
no?
chatting?
We just have a phone call. I'll definitely have him on the podcast for sure at some point.
Yeah,
I can't wait
his
to interview.
papers. I love his papers. I haven't listened to Rhonda's interview with him.
That's
but
great.
Yeah. So what gets you excited about? I mean, part of the mechanisms associated with fasting are the AMPK and the mTOR inhibition, glucose inhibition that we kind of talked about. But there's also the ketone elevation. So what aspects of nutritional ketosis gets you personally excited?
I mean, I think it's just one of those things. It's a tool. It's one of 100 different named diets out there, and there are some people for whom it's really effective. There are some people for whom it's not particularly effective, and I've seen plenty of cases in people in whom it is awful. Actually, it seems to make everything go worse. So. If I were to think of one disease state that seems to benefit more from a ketogenic diet than any other, it's type 2 diabetes. I mean, type 2 diabetes really seems to have a ketogenic diet as its kryptonite. Again, probably not uniform, because nothing in biology is, but that seems to be an example of where this tool is really effective. Now, it's probably not as effective as fasting. I would argue that fasting is the single most important tool to treat metabolic disease. And I think that whether you're talking about NAFLD, type 2 diabetes, insulin resistance, I think that fasting should be a really important part of any protocol there. But you can't fast indefinitely, so you have to be able to come back to something. And so intermittent fasting, in whichever one of those 50 that we think makes the most sense, is relevant. And then I think you want to come back to some combination of dietary restriction, again, of which ketogenic diets make sense in some circumstances, and maybe even coupled with some time-restricted feeding in there as well. I always try to differentiate between time-restricted feeding and intermittent fasting, though those terms get used interchangeably. I think we should do a great job to separate them. Time-restricted feeding is like the daily 16, 18 hours or whatever of not eating. Intermittent fasting means you fast for an intermittent period of time.
So that's a very interesting point, something I've had some theories around, where if people are doing the different intermittent fasting strategies, let's say one day they eat at 6 and the next day they eat at 12, we know that obviously light is a good entrainer of our circadian rhythms, but as is food intake. Do you think there's some circadian disruption inadvertently through willy-nilly intermittent fasting protocols?
Yeah, there might be. And I actually look forward to having Sachin Panda on the podcast to discuss this with him, because I think that's, to me, one of the most interesting parts of circadian rhythm. And also, you can then start to, you alluded to this earlier, and I sort of glossed over it because we've got into some other topic, but you can also use food as a way to, for example, treat jet lag. So many of our patients are traveling all the time, and it's more than just a East Coast, West Coast. I mean, it's significant 6-hour jumps. So food can become another tool to actually help you reset to the new time zone and back. So yeah, it's super interesting. And I don't know the answer to your question, which is going back and forth between different windows of feeding disruptive to the body. It certainly might be, but again, everything has to be weighed through the context of like the dose effect. People, I'm not saying you've done this, but so many people, especially in social media, they get so phosphorylated over something that may be relative, or may be relevant rather, but the dose effect is so small. It's like let's think about like the log sitting over here and not the toothpick sitting over here.
That's a good point.
So you always want to sort of keep that in the back of your mind. So if your sleep takes sort of a 3% hit because of the not perfect timing of your time restriction, but you get a 25% metabolic benefit from it, you just have to weigh those things out and ask yourself the question, like, we're playing a macro min-max game, not a local min-max game.
Yeah, good point. I've never heard the word phosphorylated used in that context, but it seems I like it.
It's absolutely one of my favorite ways because you can just imagine like all of the phosphorylation that's happening as people get so pissed on Twitter.
They do, man. I mean, people get really, I mean, they root down in their biases, and if you say something to the contrary, they just like go nuts. It's really...
I'm really learning well from Sam Harris, so I almost don't engage on Twitter at all. I mean, and I'm not like, I don't tend to be, I think I've probably only lost my mind on Twitter twice, but I'm at the point where like you can't go a day without seeing someone chime and pipe in at you with some ridiculous comment, and it's actually great training to just be able to look at that, feel yourself get annoyed, and go, okay,
let it pass.
Yeah, let's go.
Interesting. Going back, you mentioned that some people don't do well on keto. Do you think those people are the quote-unquote metabolically inflexible, or they're already...
No, I think there's something else going on.
Something else.
Yeah, because by definition, anybody with type 2 diabetes is metabolically inflexible.
Yeah.
I mean, again, we should be clear on how we define metabolic flexibility. By my definition, metabolic flexibility is a fuel partitioning issue. It's and by definition, if you have type 2 diabetes, you don't partition fuel correctly.
Right.
So I don't think that's it. I think there's something else going on, and I don't know what it is, but it almost assuredly has to do with the enzymes that regulate ketogenesis would be the first place I would look. Because one of the things that we do see in people who struggle with ketogenic diets is they don't tend to get glucose and ketone homeostasis despite being adherent to the rules of the diet, eat this much carb, this much protein, this much fat. So now that said, we've had patients who have really struggled on ketogenic diets and they've had very little benefit. And if we kickstart them with a fast, it actually becomes a little bit easier to stay in ketosis outside of the fast. So it could be that the fast forces that, because fasting is, starvation ketogenesis, which is similar pathway to the nutrient-rich nutritional ketogenic pathway. But they have things in common. They both still have to be able to turn fat into beta-hydroxybutyrate. The question is, are they doing it from endogenous fat, meaning breaking down your own fat to do it, versus the outside? So the advantage of the fast is everybody within about 7 days of a fast has unmeasurable insulin levels.
Right.
And at that point, your free fatty acids are up, and then pretty much everybody's going to be able to make ketones. Now, between days 0 and 7, you can see a lot of variation between people.
A lot of fluctuations there. Yeah, I love that. So AMPK is a mediator. I think on your Instagram, you have obsessed with, there's a lot of different things.
I have a lot of things I'm obsessed with.
mTOR and then AMPK is on there, right? So we did kind of infer, we alluded to AMPK and so forth, and I think it's kind of interesting. And maybe before we dive into that, one burning question that's unrelated to that is the U-shaped curve associated with autophagy. So we hear that autophagy is great with longevity, but is there tissue specificity and maybe in neoplastic cancer type situations where too much...
I think so, yeah. I mean, I think any extreme, when you look at, knockouts, so either autophagy always on knockouts and impossible to undergo autophagy knockouts, I mean, these are both not compatible with the life we want to live. So yeah, I think most things in biology are U-shaped and inverse U's.
Okay.
Where too much or too little is usually a bad thing.
Yeah. So AMPK, maybe if we could just kind of briefly review for everyone, and then why are you personally excited about it?
Well, I mean, it's partly just tongue-in-cheek in the same way that I'm excited about all of the nutrient-sensing pathways, but AMPK is an enzyme that goes up when we are void of nutrients. So it's basically another one of these nutrient-sensing enzymes, but more so on the gluconeogenic side and the glucose side, whereas TOR is very sensitive to amino acids. And it's an interesting enzyme because I think the observations around metformin, which have a lot of people pretty excited. I had Nir Barzilai on my podcast a while ago, and I don't think you could find a person who could speak more completely on the subject of metformin and its possible utility as another one of these longevity agents like rapamycin. And one of the things that metformin does is it activates AMPK, and a result of that is the liver puts less glucose into circulation. And so for someone with type 2 diabetes, that's a really good first step. And that's why metformin is probably the safest and certainly one of the most long-term efficacious drugs in the treatment of type 2 diabetes, which then begs the question, does it offer benefits to people who don't have type 2 diabetes? I think that's the question Nir and his team are trying to answer. I don't know the answer to that question. I mean, I think that fits in the category of the more metabolically ill you are, probably the more benefit you get from metformin. So that's, I think, been borne out almost unmistakably in the patients with type 2 diabetes. I think it's, even though so many of the data are retrospective, the overwhelming common directionality of the outcomes, the magnitude of the benefits, makes it seem very likely that metformin is a net positive in somebody who's insulin resistant or has diabetes. Conversely, when you ask the question in a perfectly normal, healthy, insulin-sensitive individual, one, does it offer benefit? And two, is the upside greater than any potential downsides? And I don't think we know that yet, and that's why I think it's going to be really exciting to see TAME, which is the study that Nir's talking about, funded.
And so for you personally, do you take metformin?
I have. I mean, I've taken it since 2010, I think. I'm not taking it at the moment. I'm sort of doing an experiment with and without it to see, because I do think that my lactate levels tend to run higher when I'm on metformin, and I'm talking really low level lactate. So lactate at zone 2, which is kind of what I think one of the 4 important pillars of training is maintaining that super aerobic efficiency. Where you shouldn't be generating any lactate, right? So it's basically what's the most ATP you can make without making lactate. And I feel like, and again, just based on my own data, but I do so much of this testing on myself, that I just feel like metformin is impairing my ability to make ATP at low lactate levels, at low levels of intensity. Now, is that clinically relevant? I have no idea. Is that enough downside to offset the upside? I have no idea. And so right now I'm just trying to get a sense of that.
To wean off and then compare the lactate levels.
I'll go off it for a month and do, 1,000 lactate pricks during training and then be on it and then try to compare the difference in both starting lactate levels and lactate response against a fixed resistance like a power meter.
It's interesting. Now, obviously we can't give health advice and so forth on this podcast, but would 500 milligrams of metformin be like a low dose for someone that's metabolically healthy just to kind of dabble and experiment with, would you say? Or
I don't know. I mean, I certainly for someone with insulin resistance, it's not. I mean, we typically treat people with 2 grams per day, a gram in the morning, a gram in the evening. We start everybody at 500 milligrams per day just to reduce the GI side effects. So we always start people at like 500 milligrams before bed. We let them ride that out for a week, and then we had 500 in the morning, let them ride that out another week, then 500 in the morning, 1,000 before bed, and then so after a month you'll work up to 1,000 morning and night. So I don't know if there's enough benefit at 500 once a day.
So when you were taking it was more like 1,000?
Yeah, I mean I was taking the party dose.
I see. The party dose. That's funny.
1,000 twice a day.
What about berberine? Hydrochloride. Have you experimented with that? And
yeah, I have. I mean, I don't think you'd want to use berberine and metformin together.
Sure. Because
they both would tend to go after the same pathway. And berberine, of course, is much weaker. We don't typically use berberine for that purpose. We use berberine for another property it has, which is inhibition of PCSK9. It's a weak PCSK9 inhibitor, but it seems to only inhibit in patients that overexpress PCSK9. So if you took the average person who has normal PCSK9 expression and you gave them berberine, I suspect it would have no impact on their LDL. But if you took someone whose LDL was elevated because of a PCSK9 overexpression, you could see maybe a 20% reduction with berberine.
In their LDL?
Yeah.
Wow. At 1,500 milligrams?
Or typically a gram twice a day.
Okay.
Yeah.
Interesting. Last compound, spermidine.
I haven't used it at all.
seen some of the research. I mean, I guess it's in trace amounts in onions and different foods and things like that, from what I gather. But
is it? I don't even know.
Yeah, there were some papers talking about it in its autophagy activation or something along those lines.
I haven't seen any data in humans. I mean, I've seen some of the animal data, but have there been any trials in humans, even looking at short-term stuff?
Yeah, just it's some of these review papers where they highlight different animal model studies, tissue culture studies, and they say these are all the things. So it's been showing up repetitively. So I was curious.
Yeah, I'm trying to think. I feel like I was just talking about it with somebody. It might have been Dom D'Agostino. I don't know. I don't remember who it was that I was talking. I had an interesting discussion about this with somebody 6 months ago, and but yeah, I guess it'd be interesting to see something in human literature. It's so easy to get fooled with any compound in any one particular animal model,
right?
And that's why, to me, the rapamycin story is so interesting, because you see the same benefit, roughly in the same magnitude, in the same direction across 1 billion years of evolution. And you have to think about that for a second. Like, what does that tell us, right? When you have something that is so conserved that for the last 1 billion years it hasn't changed, and we can tweak it in the same direction each time. Again, there's no such thing as proof in biology. I mean, biology is not mathematics. There is never a proof. So it's all probabilities. But that would strike me as important an observation as anything else when it comes to the certainty around which that compound matters, versus you can almost find any compound that on a good day with a tailwind can impact one animal model in one direction.
It's interesting you bring that up. I think the NR story is kind of following, and I'm not picking on them in particular, the resveratrol trajectory, because remember in 2007, 2008, David Sinclair started talking about sirtuins, and resveratrol came out, and it's kind of interesting to see these animal model studies and so forth.
See, I actually think the resveratrol, so I everything you're talking about I'm very familiar with. In many ways, I think the resveratrol model is more appealing to me than the NR model. Like, whether resveratrol was the right molecule or not, or whether it was delivered correctly or not, those are debatable. David would argue, not delivered correctly, right? Very fat soluble, not delivered in the way that it was, taken up. But it seems to me that it should be easier to activate sirtuins than the problem of trying to get NAD into mitochondria. That seems like a really hard problem. And, I hope that, I guess, I don't know. I don't really follow this space that much, but I know that one of Elysium's sort of claims is they want to do really good research. So presumably, they're working on figuring this stuff out and demonstrating it in humans.
Interesting. And that would require a biopsied muscle tissue? Or?
I think so. I don't see how you could get answers to these questions in humans without biopsies.
Yeah. Few follow-up questions, because I know you have a tight schedule here. So what do you say, there's so many different ideas about what does or doesn't break a fast. And so I have my own way of wording it, but I'm curious to hear what do you say to that? Does celery break a fast? Does coffee break a fast? I'm sure you get these questions all the time.
Yeah. Well, again, I preface it by saying nobody knows, so we should just it's funny. You ever listen to that podcast Slow Burn?
I've seen it.
It's a production of Slate.
Okay.
Yeah, it's incredible. And I just finished binge listening to it, because with all this easy aerobic training I do, you'd just go crazy if you were just listening to music. I have to, that's sort of that 3-4 hours a week I spend doing that type of training is where I consume all my podcasts. So anyway, one of the programs they had was on the Clinton-Lewinsky scandal, whatever you want to call it. So I just got a little refresher on that. It's 20 years ago. It's hard to believe.
Wow.
And so I'm going to make a joke, which is basically the definition of what breaks a fast is as subjective as the definition of what is sex, right? And Clinton had his own definition, and we could all argue that maybe he went a little too far with his definition. But what is the definition of sexual relations, right? So what it comes down to me is ask the next layer question. Okay, so for example, and again, I can't believe I'm doing this, but if someone is sitting there and he's sort of debating with his girlfriend whether he had sexual relations with that other girl, one proxy might be, did whatever you do, was whatever you did with that other girl, would you have done it if your girlfriend was standing there?
Yeah.
Right? So talking to her, yeah, probably not sexual relations, right? But making out with her might have crossed that line.
Sure.
So similarly, I say if the question is like, what is breaking a fast? It probably depends in large part on what is the purpose of your fast. So if the purpose of your fast is caloric restriction and weight loss, I don't see how coffee is breaking that, and I don't see how celery is breaking that. If the purpose of your fast is gut rest, which I think is an important part of fasting, then I think both of those are probably tweaking your gut. If the purpose of your fast is autophagy, I don't think we know, because as we talked about earlier, how do we even measure autophagy in humans at a practical level?
Right.
So I really don't know. So it's one of those things where I think people just have to ask a second order question, which is, why am I fasting? And if you answer that, it won't give you the definitive answer to this question, but it will at least point you in the right direction.
That's usually, I reply with, what are your goals with this? Same thing. So that's a great way to look at it.
And it's a lot quicker and easier than my stupid
Lewinsky story. I like that analogy. Stories and analogies, people love that. Just a few final questions. So we've talked a lot about mechanisms and all that, and I love diving into that. But we have a healthcare crisis in the U.S., right? So on a top-down level, and maybe you've had these conversations with politicians before, you're at that level, what could be one malleable factor within our kind of socio-political system that we could manipulate that would improve the health of possibly our children and then baby boomers and so forth? Do you think there's one thing that's like, if we just...
You could pick a dozen things that would all have a positive impact. I can't even begin to imagine rank ordering them for what would have the greatest impact. So that's the first comment. The second comment is, answering a question like that sort of requires a second order layer of thought, which is, are we in the United States? Are we in a benevolent dictatorship? Are we talking about like waving the magic wand type solutions, or actual solutions like legislative solutions or public health solutions? So again, if you ask the question theoretically, like, you are health czar for a day, and by snapping your fingers you could make 3 things happen, that's a really fun, interesting question. If the question is, you're one of the 500 plus members of the House, or whatever, the 460 members of the House of Representatives, and what bill do you want to take to the floor to make a change? I don't know. I can't think of anything that's that interesting.
Yeah, no, that's fair. So you're a pretty successful guy, right? You run this podcast, you got 3 great kids, all that. We know that successful people have a morning routine, a set of practice rituals that they do. In a few minutes, what do you think is unique about your morning routine, and what do you really do that sets you up for success for that day?
Oh, well, first of all, I appreciate that. I'm not used to being called successful. It's sort of a funny thing to say. Sort of like something when you're done, people should say, maybe you were successful. So I like to get up early, and first thing I want to do is sort of meditate. So I use one of 2 apps very commonly, 10% Happier and Waking Up, which is Sam Harris's app, and Dan Harris, no relation.
That is funny.
Yeah, I know. So I love those apps, and I usually like to do a lesson and a meditation together. So you'll listen to a lesson, which in many ways sort of gets you ready to think about this, the day a little bit, and then do a meditation. I love to make coffee, so my wife likes it if I make her coffee. There's not much I can do to improve her life, but making a really good French press is something I like to do. And then usually I'm trying to limit email checks to twice a day. As I describe it, as my effort to avoid becoming the least productive human on the planet. So I usually do a big batch of morning emails while I wait for kids to wake up. And then I kind of just want to play with the kids as much as possible. And then once they go to school is usually when I work out. So I think that part of my day is generally pretty much the same all the time. And then after that workout, then obviously the day can go in any different direction.
Right. And then when do you do your deep work, your writing, your reading? Is it usually in the morning, or do you push it in the afternoon?
Yeah, unfortunately, something had to go, and I would love to have made the morning and I've experimented with those things where I make the morning,
creative.
The time when I do that, yeah. But the problem is then I'd have to give up a lot of other stuff that is really important in the morning. And probably the most important thing in the morning, I think, is like kind of hanging with the kids.
Totally.
So, and I couldn't do that work in the way that like our household works in the morning. So unfortunately that work tends to get suboptimal time. Although airplanes, believe it or not, given how frequently I fly, tend to be where I do my best writing.
Me too. What do you think that is? Is it no Wi-Fi, no distractions? What?
I don't know. Because it's not even the no Wi-Fi. Like I still have Wi-Fi on when I'm writing because I'm using Google Docs and I like to be able to, have it sync in real time and stuff. It might just be like there's something about a finite window of time. It's like basically you have 5.5 hours and I just look forward to, I hate flying so much, but I've come to look so forward to that window of time to write that I sort of get it done.
Interesting. Yeah, I've done some of my best work, I think, on an airplane. It's really weird. I've kind of thought about that. So you have a lot of tools that make you healthy. You talked about when you travel, you like to bring, the thing over your eye cover, stuff like that. What tool or herb or supplement, what could you not live without? Like if there was one thing, your house is burning and you're running out with this one thing, what would it be?
Well, I don't think it would be any health-related tool if my house were burning. I'm assuming all the kids are out. So health-related tool. Maybe that's not a best analogy. Maybe you're going to live on a desert island with a family for a year, and you can only bring just limitations. One health-related or supplement, pharmaceutical, just one compound, one thing. What would that one thing be? Well, that's an interesting question because presumably on a desert island, you're going to be eating pretty well because you're going to be eating lean and mean and killing some fish and eating some coconuts. So I don't know that I'd have to bring any drug. Boy, that's a really good question. I don't know. I think if I was on a desert island, I wouldn't need anything.
You'd just be good.
I think I'd be pretty damn good. Maybe a Speedo and some goggles.
Your bow and arrow?
Yeah.
I need the bow and arrow.
There you go.
Yeah.
That's exactly right. That's what I'd bring. I'd bring the bow and arrow.
That's awesome. Yeah, we were at a conference over the weekend, Low Carb Denver, and I spoke with the folks, and they want to have you as a speaker there potentially next year. And a gentleman, Robert Sykes, he had his bow and arrow, so we were in the parking lot practicing in the evening. Well, so this is right by the airport in DIA in Denver, so there's no one for miles, and so there's a big
snow bank. And you set up some targets?
Yeah, it was really fun.
That's cool.
Just the meditation, like you have to really be present and intentional.
It's awesome.
So it was fun. So Dr. Peter Attia, really appreciate you coming on the show.
Thanks for having me.
Peter, or if folks are listening, people are listening right now and they want to connect with you. I know you have a great podcast, which they probably already listened to. But where should they go? Like what one online resource, Instagram, your website, where should they go?
Probably the website and on social. They're all the same. It's all Peter Attia, MD.
Yeah.
So Twitter, Instagram, and the website are probably where I spend the most time.
And then you have a membership portal, $4.95 a month, I believe.
Well, it's a pay what you can
sliding
opt
scale.
in, yeah. And so everyone gets to hear the podcast for free. There's one every week, and usually there's a bonus one every once in a while. So I'll probably put out 55 to 60 podcasts a year, and those are all free to everyone. I don't think Mike will pick him up.
No, it's fine. We're winding down. It's good.
But the members get 3 other main benefits. One is they get all the show notes, and our show notes are really exhaustive. Yeah, they're about 20 pages per episode. And then they get to participate in the AMAs. So we have an AMA portal, so people can ask questions, and then I do a monthly AMA. And then because I didn't want to take ads, but there are a bunch of products I really love that I thought, well, let's flip it instead. Instead of me taking ad money, I will go to companies that make products that I like and say, look, you would have given me this many dollars to advertise on my podcast. Let's divide those dollars up and distribute it as discounts to people to buy your product. So we'll give the subscribers a code and they can go and buy it. And I'm not involved in the financial transaction. So I don't feel like there's a conflict of interest. And everybody kind of wins on all rounds. So those are the benefits of being a subscriber.
Yeah, they definitely should support your work. There's no other podcast out there that I think goes into that level of depth. So very much appreciate you.
Thanks, man.
Yeah, thanks for coming on.